In terms of the risk factors, we know that certain ethnicity are more prone to it. For example, I mentioned that Caucasians have more hip OA, whereas Asians have more knee OA. Gender, the females tend to be a bit affected more postmenopausally, but of course, as the age progresses, the males catch up very fast. Older age tend to have more of this condition. Some of them are hereditary. We have patients where the parents also have osteoarthritis and they tend to have it more seriously. Hypermobility is a condition where the tendons are a little bit flexible in some patients. And because the tendons are not so strong and they wobble, they cause the joints to wobble more. And because of that, the wear and tear can happen more, or the mechanical sort of imbalance can happen more. And so people with hypermobility may have more osteoarthritis as well. But what we can do is we just strengthen the muscles, and that will help to take over the function of the tendons. And again, you will prevent osteoarthritis from happening. Estrogen is believed to be protective, and so after menopause, females may be more prone to osteoarthritis. Obesity is a very well-known risk factor. In fact, it's well known that if you can lose 5 kg, you can reduce the chance of surgery by 30%. So actually, weight loss is a very important way to prevent the need for surgery. Smoking is also not good for the joints. In some patients where there is osteoporosis as well, there can be accelerated osteoarthritis, especially if the bone collapse. And when the bone collapses, the joints can become more deformed and the mechanical sort of imbalance become worsened, and that may aggravate the progression of osteoarthritis. So in many patients, we do try to treat both osteoporosis, if they have them, and osteoarthritis together. Nutritional, we don't have a lot of evidence yet, but we are still trying to find out what are the important aspects. Maybe vitamin D will be useful because it strengthens the bone and also strengthens the muscles. Now, so in terms of all the local biomechanical factors, what we try to prevent is joint injury or deformity. So whenever there's any sports injury, we try to treat it well, so it doesn't become a permanent misalignment of the joints that can cause mechanically disadvantageous joint movement and therefore aggravate the possibility of osteoarthritis formation. Weak muscles is again a contributing factor, so we always encourage exercise to strengthen the muscles because that can protect the joints and prevent worsening of the osteoarthritis. Obesity I've mentioned earlier. And of course, because of all these different risk factors, it can affect the different joints slightly differently. Here is a picture or cartoon showing all the chemicals that can be produced by the different sort of cells in the body. So you can see that there are chemicals like IL-1, nitric oxide, TGF-beta, TNF-alpha, etc., and also prostaglandin here. But basically what it's telling us is that there are many different things that can cause the wear and tear to happen in the joint that is biochemically driven. But as I mentioned earlier, there isn't a magic bullet to target any of this. Yeah. But what we know is that for prostaglandins, you can use non-steroidal anti-inflammatory drugs to reduce the inflammation by inhibiting the production of prostaglandins. And that's why drugs like NSAIDs, such as Simplex, Arcoxia, they are all quite useful. Yeah. Now, in terms of the symptoms, I think pain is the biggest problem that's faced by our patients. In many of them, they also have stiffness in the joints, but classically it's less than an hour. And there's limitation of the movement of the affected joint. There may be a little bit of swelling, but it's usually not as bad as the other inflammatory arthritis. And when the doctor examines the patient, or even if you feel your own joints, or patients who felt their own joints, they can find crepitus. In other words, there's a bit of creaking sound as you move your joint. Bony hypertrophy, in other words, the hard lumps that you notice in the fingers and in the ankles, or rather in the knees. Sometimes you can also feel certain osteophytes or the bony swelling. The bone can be tender. There's again loss of the range of motion. And then sometimes the knee or the affected joint may be a bit crooked or misaligned, and that actually may aggravate the progression. And of course, because of this pain and misalignment of the joints, the gait of the patient can be abnormal as well. So most of the symptoms are driven by mechanical causes. In other words, the patient tend to feel worse when they move, and walk a lot or when they have to carry heavy objects, and they feel better when they rest. So that is a classical feature of a more degenerative arthritis. Now, here is a cartoon showing the affected joints. As I mentioned earlier, the finger joints are badly affected, sometimes the thumb as well. Then you can also affect the knees, the hip, and then the big toe. And finally, the neck area, as well as the lumbar spine area. So these are the common sites. So in the knee, you can see how the medial side of the inside of the joint is usually more badly affected. And because of that, you can see the bones are almost touching each other because the cartilage are all worn out. And then in the big thumb, there's actually one joint called the metacarpal joint that can be badly affected. And that's why some patients, they do feel a lot of pain around the base of the thumb area. And then in the neck and the lumbar spine, again, there can be all this wear and tear. And here you can see the osteophytes, or the bony swelling that is in the back lumbar spine. And again, this can cause problems in terms of pain and sometimes even impingement on the nerves.